into the heart? So, oh, I can't spell at all. I won't look at that. I have to fix that. Okay, anyway, basic structure of the heart. So we've kind of, like I said, you looked at that in your other online activities. We know the atria are the receiving chambers of the heart. So we always see veins leading into the atria. You have the superior and inferior vena cava bringing used blood back from the body to the right atrium. And then we have the pulmonary veins bringing freshly oxygenated blood back to the heart to the left atrium. So the left and right atrium are receiving different types of blood. Blood from the body that's used in low oxygen and blood from the lungs that is freshly oxygenated. And then we have the ventricles. We have the right ventricle here and the left ventricle here, and they're divided by this sulcus, which is the anterior ventricular sulcus. And we see some coronary arteries lie in that sulcus, as well as cardiac veins. So the right ventricle, the left ventricle, both are the pumping chambers. They pump blood away from the heart. So atria are the receiving chambers, bringing blood into the heart. The ventricles pump blood away from the heart, and they pump those into arteries. Arteries always lead away from the heart. So the right ventricle pumps blood to the lungs via the pulmonary artery, and the left ventricle pumps freshly oxygenated blood to the body via the aorta. So the ventricles are always feeding into arteries, and the atria are always receiving blood from veins. Okay, so that's just kind of just a basic layout. So if you think about function-wise, and you look at the blood vessels lying over the heart, which chambers are more important? That if they're not contracting well, we're going to have serious side effects very quickly. Atria or ventricles? Ventricles, yeah, because they're pumping blood away from the heart, getting it to the rest of the body. So if the ventricles aren't doing their job, we're in trouble. So we're going to talk a little bit about that. So if we slice away the front side of the heart, we can see the insides of these chambers. So we can see that the right ventricle is here, left ventricle is here. There's the AV valve. So this is the tricuspid or right AV valve. This is the mitral valve or the left AV valve. They have these special chordae tendineae to prevent them from flapping up into the atria when blood passes through them. Most of the time, these valves are open. Most of the time, they're open. The only times that they're closed is when the ventricles contract and the force of blood pushes them closed. But otherwise, when the heart is relaxed and filling, these valves are open. Then the other valves we see are at the base of the arteries. We have the pulmonary artery, which would be up here in the roof of the right ventricle, and then peeking out underneath here is the aortic valve, which is in the roof of the left ventricle. These do not have the chordae tendineae on them, but they have these cusps, kind of like a half moon shape, somebody thought. So they're called semilunar valves based on the shape of them. So these valves can wear out over time, and people do come in, usually in their 80s, for valve replacements. Typically, it's the mitral valve that wears out, and that's because the left side of the heart works a lot harder than the right side. Because when you did your coloring or your online activities looking at blood flow through the heart, hopefully you noticed that the right side of the heart pumps to where? To the lungs. And the lungs are pretty close to the heart. So it's a low pressure system, the right side of the heart. The left side of the heart has to pump to the aorta and to the rest of the body. And there might be resistance out there if there's cholesterol buildup, narrowing of the arteries, hardening of the arteries. That left ventricle has to work a lot harder. And because of that, we see a much thicker wall on the outside wall of the left ventricle, and we see a failing valve because the pressure of that blood up against that mitral or AV valve can cause that to become leaky and not to work as well, and then people need a valve replacement. Sometimes they put an artificial mechanical valve, we call it, in, or sometimes they'll use a valve from a pig's heart. So it's called porcine, P-O-R-C-I-N-E. You don't have to write that down. But if you ever see it written somewhere, a porcine valve is a valve from a pig's heart. And then looking at the layers of the heart, the outer layer of the heart is the epicardium. So when we shock somebody, when we put the pads on them, we're trying to get that electrical impulse through the epicardium to the myocardium, which is here. This is the muscular wall. That's the part that contracts. So if we need to get that heart to contract because it's not doing it on its own via an action potential, we're going to just send direct electrical impulse to those cells to get them to contract. And many lives have been saved using, AEDs. Or even if we have somebody with a really funny rhythm, sometimes they don't get an AED where they just get shocked randomly. We'll have them come in during a scheduled time period, and we have a machine that does the same thing, but we time it with their heartbeat. Like if they have a funny heartbeat, we'll time it with the contraction of the ventricles, and it's called a cardioversion. Cardioversion is when you put the pads on the chest and you put it at just the right time, you deliver that electrical impulse. And that's good for fixing a bad rhythm. Some people getting these really bad rhythms like atrial fibrillation, and sometimes you can fix that with a timed shock to the heart. So we're trying to stimulate that myocardium. So myo, think muscle. And then on the inside is the endocardium, and this is the slippery inner surface. This is what's in contact with the blood. So if you have inflammation of the endocardium, that is very serious because that's going to interfere with blood flow. So some people, IV drug users, are one of the higher risk groups, will develop endocarditis, and it's an inflammation on the inside of the heart. So we look at people that come in with that as their only primary problem and wonder, what's going on, what is their history? Because when we're injecting particulates, little suspended solid particles of drugs, and who knows what else are in those drugs, where they're prepared and what's, how they're transported, what's in there, that can cause infection and inflammation on the inside lining of the heart. And I've seen patients that are in their like early 20s, late teens, IV drug users that have come in, but by the time they come in, their endocarditis is so severe that they have permanent heart damage, that they'll be on disability and never be able to work again. And all because of early drug addiction. Very, very sad. So if we look again at the different sides of the heart, we can say that the right side of the heart is the pulmonary circulation. It's all shown in blue there. So here's the tissues of the body that have used up the oxygen. So the capillaries, the veins, bring that blood back to the heart, to the right atrium. So you have the superior and inferior vena cava, sends it to the right ventricle, pumps it up to the lungs via the pulmonary artery. The lungs oxygenate it, brings it back via the pulmonary veins, down to the left ventricle, left atrium first, left ventricle, and out via the aorta and all of its branches back to the tissues. So the pulmonary circuit is the right side of the heart. The systemic circuit is the left side of the heart. Which one do we say is higher pressure? The systemic circuit, right? So if we look at how the muscle cells that make up the myocardium are arranged, we'll see they have this kind of special wrappings. And because of the way those muscle fibers run, kind of tells us how the heart works. When it receives an action potential, it squeezes from the tip, the apex, toward the top, which allows that blood to kind of be like a washcloth. If you want to get all the water out of a washcloth, don't you squeeze it from the end and work your way to the top? The heart works the same way. So the way that muscle is bundled kind of tells us how it functions. You can see here toward the top, the atria have a similar arrangement of the tissues, of the muscle tissue. So when they contract together and they bring that blood downward. So they wrap around the atria and just bring that blood downward, where we can see how it spirals at the tip, kind of causing a twisting motion. So the heart kind of has a slight turn to it when it contracts, which forces that blood in the apex up toward the aorta and the pulmonary artery. So if we look inside there, but the left and right ventricle carry the same volume of blood, and that's a key concept. It looks a little different in there, but the volume is the same. So different pressures, same volume. So the left ventricle has high pressure, but same volume of blood is pumped with each beat. But it just looks a little different. We can see that the right ventricle goes up a little higher on the heart. Can you see kind of this slight little indentation here? That's the bottom of the right ventricle, where the left ventricle goes all the way down to the apex. And again, it's contracting under high pressure, so we see a much thicker wall lining the left ventricle. And this is that septum that divides the right ventricle from the left ventricle, but you can definitely see the thinner wall on the right side. So if we look at the circulation over the surface of the heart, because this muscle of the heart is working so hard, we would expect to see a lot of mitochondria in cardiac muscle cells, right? Because what happens in the mitochondria that we studied this semester? Making ATP, right? Krebs cycle, electron transport chain. So that important aerobic process for getting lots of ATP happens in the mitochondria, and the heart is pumping, 80 beats per minute from the minute where our heart starts pumping, 8 weeks, post-conception. So it's been going a long time. So as a result of that, it needs a fresh, steady supply of oxygen and nutrients. So if we look at the circulation over the surface, this is critical for feeding that active muscle. And if we get a clot in one of these vessels, what do we call that? A heart attack. The fancy word for it in the clinical environment is myocardial infarction. Yep, myocardial infarction, or MI. So we can see, where do those vessels originate? Where does that blood, how does that blood get over the surface? Where did it start? If you were designing this heart and you wanted to make sure these arteries supplied freshly oxygenated blood to this heart muscle, where would you hook it up to get the blood over the surface? What? Yeah, the aorta. Exactly, and that's where the coronary circulation starts, is at the base of the aorta. So you can kind of see there, if you look through, the aorta lies behind the pulmonary artery, so it's a little bit hard to see. But you can see there's two of them on either side of the aorta, one here and one here. It's right at the base of this aorta, where that fresh blood supply comes up over the surface of the heart. So if we think about the importance of the heart and the importance of the chambers, and which one is going to supply blood, or the greatest force of blood to the system, that's the left, correct? And if you look at the vessels and how they're arranged, which one do you think, if it gets a clot in it, is more likely to lead to death? What would you guess? Which one supplies more of the heart? I hear people saying it. Say it a little bit louder. Yeah, the left coronary artery. Yeah, that's pretty serious, because if you see the branches of that, quite a few branches, so if you get a clot in the upper portion of that, that's not a good thing. So what they do is, when a person has an angiogram or a heart catheterization, they put a dye up through the vascular system, through the femoral artery, up all the way, working its way up. Sometimes you can use a radial artery in the wrist, which is nice, but they'll work it all the way to the heart, and they'll shoot a dye into the vessels that you see here over the surface of the heart. Then they'll take an x-ray and they'll look for blockages. And once they find a blockage, sometimes they can go up with a thin wire and put a stent in there and open things up, and they'll be fine. Or if it's too blocked and they can't get a stent in there because it's so occluded, then they have to do bypass surgery, and they'll have to go around that clotted vessel. So when we need to take that blood back to the heart, we need to drain, right? We need to drain the used blood from the heart, the low oxygen blood, over the heart muscle, and that happens via the cardiac veins. So we have these cardiac veins that drain to the coronary sinus, and the coronary sinus hooks up where? Where does all used blood come back to from the heart? To where? Yeah, the right atrium. So the coronary sinus hooks up with the right atrium, returning that used blood back to the heart. So when you talk about the circulation, we can't forget about the circulation over the heart, because if the heart stops pumping and doesn't get the blood and nutrients it needs, the rest of the systems will die as well. So what they say, time is muscle. When a person is starting to experience chest pain, burning sensation, shortness of breath with activity, they need to be seen as soon as possible. Not, oh, Grandpa, hop in the car and I'll drive you. Sometimes it's best to have the ambulance come to you, because they can give you things right at your house. Where if you want to take, a 30-minute drive into the hospital, it might take them 15 minutes, lights and siren, and the minute they arrive, they can start treating that heart attack, rather than you sitting, or someone else sitting in the car and then walking into the ER and all that. It's better to have them get there, put the person on oxygen, give them some medicines right away, and stop that process, or at least slow the process. Very, very important that people not drive themselves in. I have a friend whose father-in-law died in the parking lot of the ER in the hospital because he wasn't feeling well, felt a little funny, and decided to drive himself to the hospital, but he had a heart attack in the parking lot. And that is not the first time that that's happened. They said it's a problem that they need to get the word out there. Time is muscle. call the ambulance, get them coming if you feel a person is having heart attack symptoms. Don't try driving yourselves. Okay, so we talked about the valves. The key function of the valves, or at least we looked at the valves, is to prevent backflow. So if you're going to highlight anything on the slide, preventing backflow is the importance of all valves. We want to keep forward flow through the heart. And only the AV valves, remember, have those chordae tendineae, which keeps those valves from flapping up into the atria when the ventricles contract. So we talked about the semilunar valves are at the base of the aorta and the pulmonary artery, so they prevent backflow when the ventricles contract. And if you look at a top view here, you can see how they close tightly. We'll talk about what causes them to close, but as long as they close tightly, we're going to hear the lubbed up, lubbed up, lubbed up of the heart sounds. That's from the sound, that's the vibrations made when the valves close. That's the heartbeat that we hear when we put a stethoscope over someone's chest. If there's a little extra sounds in there, that means there's a heart murmur. And a murmur is incompetent valve. So something's going on with the valve. It's either stiff or it's open and a little bit of fluid is squishing through or flowing through. So sometimes you'll hear like a bump, whoop, bump, and that's what it sounds like. It almost sounds like a washing machine. You know what your washing machine sounds like when it's starting out? It kind of goes whoa, whoa, whoa. That's what it sounds like when someone has a murmur. So you'll hear that extra little vibration in between the heartbeats, and that means blood is flowing backward through the heart. It's not working. So what happens if blood flows backward? Are they getting enough oxygen to their tissues then? Depending on the level of the murmur. Some people have very mild murmurs and they do just fine their entire lives through it. Other people, they're more severe. There's like level 1 through, I know level 4 is pretty serious. I'm not sure what the ending of the levels is, but a level 4 murmur is much more serious. And those are the people that come in for getting valve replacements. So this is what an actual heart looks like from a human heart. You can see the valves there. There's the chordae tendineae and the muscle that the chordae tendineae attach to, which are called papillary muscles. So what opens the valves are pressure differences. Pressure differences due to the atria or the ventricles contracting. So when we're trying to open up the AV valves, the pressure in the atria are greater than the pressure in the ventricles. So when the atria contract, the volume gets smaller, the pressure increases, and that forces those valves open. So when the valves are open, blood moves downward, and then as the ventricles contract, that's going to open up the next set of valves. So as the ventricles contract, the blood is forced upward. It pushes on those semilunar valves at the base of the pulmonary artery and the aorta. Then as the heart relaxes, like in the bottom diagram, the ventricles relax, that blood wants to flow backwards through those vessels toward the ventricles, but the flow of blood hitting those valves as it backflows forces them shut. So it's always pressure differences on either side of these valves that causes the valves to open and close. And the pressure differences are caused by contraction of the chambers leading to those valves. So let's look a little bit now at those muscle cells in the myocardium. What makes cardiac muscle cells unique? Well, when we looked at skeletal muscle, there are these long cylindrical cells with multiple nuclei. But if we look at cardiac muscle, they are striated. They have actin and myosin overlap, just like we saw in skeletal muscle, but they're shorter, they're fatter, they're branched, and they're connected by those special structures that you learned about in general A&P, the intercalated discs. Remember those? There's two things found at the intercalated discs. There's gap junctions. What do gap junctions do? Do you remember? We talked about this a little bit with smooth muscle. Yeah, the electrolytes, the ions involved in action potential development just flow from one cell to the next. We don't need channels. They just go through these neighboring little passageways we call gap junctions. So this would be one heart muscle cell on this side, and there'd be another heart muscle cell on this side. So if sodium is entering into the cell, for example, it's going to pass through and enter into the inside of this cell right next door. So if there's an action potential going on here, it's going to cause an action potential at the same time in this neighboring cell because of these gap junctions. And the desmosomes, if you kind of look at their structure there, they're just like tethering points. It tethers the cells together. So the gap junctions are for getting the action potential, and the desmosomes just tethers them together. So when they do shorten, they pull on everything else around it, and the whole heart functions as a unit. But now we don't want the atria and the ventricles, all of them together, all contracting together, right? So we have connective tissue separations, which separates some of these cells from one another. So only the ventricles contract together and only the atria contract together. We don't want all four chambers contracting at the same time. That wouldn't work for flow through the system. So intercalated discs are really key to that heart muscle contracting as a unit. Both ventricles contracting together, again, and both atria contracting together. And again, what else did I say would be numerous inside of these cardiac muscle cells? Mitochondria. So the heart needs a steady supply of oxygen to do its job. It doesn't do very well with lactic acid fermentation. So what happens when a person doesn't get oxygen? That's all they have is lactic acid fermentation. And they get that burning, pressure, discomfort sensation in their chest because cardiac muscle cells are sensitive to low pH, and that we need to reverse that as quick as we can and get enough oxygen to that heart muscle. So desmosomes tether the cells together. Gap junctions allow ions to pass to get that action potential to flow from cell to cell very quickly. And the heart behaves as a functional synctium. Synctium, which means a unit, in sync, right? You know what being in sync means? Everything's working together, so that's what functional synctium means. So if we look at the T-tubules, there are T-tubules, just like we see in skeletal muscle. It's not quite as fancy, but it is there. I'm sorry, not T-tubules. The sarcoplasmic reticulum isn't quite as well developed as in skeletal muscle, but it is there. What is the sarcoplasmic reticulum for? Do you remember that from skeletal muscle? Yeah, it stores calcium. But what we find with cardiac muscle cells is there is also calcium that comes in from the extracellular fluid during an action potential. So it doesn't need as much coming in from the sarcoplasmic reticulum. So skeletal muscle, the calcium comes from the SR inside those muscle cells. Not the case with cardiac muscle. We have some coming in from the extracellular fluid and some from the SR. And then we have the T-tubules that bring the action potential across the surface and down deep into the muscle cell. So when the heart muscle cells contract, we see two different types of action potentials. 99% of heart muscle cells are the workers that need an action potential to get them to contract. So they don't generate their own action potential. They have an action potential in response to a nearby cell having an action potential. Then it just spreads through the heart. 1% of cardiac muscle cells can generate their own action potential. We talked about this with muscle. Remember, we talked about multi-unit and single-unit smooth muscle. So cardiac muscle cells, 1% of those cells can generate their own action potential. And those cells are clustered in the electrical conduction pathway of the heart. And you learned about that in general A and P. We'll talk about that second. Let's talk about the 99% first. So the 99% of cardiac muscle cells contract in response to some stimulation. So if we look at the process, we have voltage-gated sodium channels open when threshold is reached. Then we see repolarization by potassium, just as the same as we saw in skeletal muscle. But there's a slight difference. At the top of depolarization, other channels on the membrane are voltage-gated calcium channels. And where do we find more calcium? Inside cells or outside cells? Yeah, outside cells. Because where does calcium come from? It comes from our diet, right? So we absorb it. It's in the interstitial fluid. It has special channels to bring it into cells. So we find more calcium outside cells. So if we open up a channel for calcium, the concentration gradient is going to bring calcium always into the cell because there's more of it outside the cell. So what we find then is we have a stimulus. First of all, you need some stimulus. From some outside stimulus causes sodium to flow in, and once it reaches threshold, we see a rapid depolarization due to sodium. But they're special voltage-gated channels. They're fast voltage-gated sodium channels, which means they open up very quickly in response to a change in the membrane potential. So they open up very quickly, and we see this rapid depolarization. And once we get above 20, that's when potassium channels open. And we know when potassium channels open, which way does potassium want to flow? Into or out of the cell? Out of the cell. So we see the repolarization, right? But if at the same time we're having calcium channels open, so we have calcium coming in, so potassium going out at the same time, we're going to see a slight drop, slight repolarization, but it's not as steep because we have calcium entering as potassium is leaving. But now remember, there's more channels for potassium, right? So we're going to still see this net drop, but it's going to be flattened out a little bit. So calcium, the influx of calcium causes a plateau. And that's what's unique about cardiac. 99% of cardiac muscle cells show this type of graph for their action potentials, and there's a plateau due to calcium influx. And then those calcium channels close as the voltage decreases, and then you have only potassium channels open again, and that's the end of the action potential. So if you compare this action potential to the one we saw in skeletal muscle or in just nerve cells, can you see that that one's a little bit longer? Based on the plateau, doesn't it look a little more stretched out than what we saw in the nervous system? What would be the benefit of that? So the depolarization causes the contraction, and then the repolarization is when the heart is relaxing. What's happening to when the heart is relaxing, what's happening in terms of blood flow during that time? It's filling, yeah. So if we had a very short action potential, we would end up with not very much time for the heart to fill with blood. So that plateau period allows time for the blood to fill up the heart. And anytime you get a rapid heart rate, think of the same concept. If I have a really rapid heart rate, my patient's going to pass out because there's not enough time for the blood to fill the heart, and it's pumping it out right away, and there's not enough pressure behind that blood to perfuse the brain, and they're going to get lightheaded and pass out. And that's where when people get into these really high heart rhythms, which we call VTAC, or even worse yet is ventricular fibrillation, is when the ventricles just kind of quiver, but they don't even contract. Very serious. And what we find on our floor is VTAC leads to ventricular fibrillation. So when we see little runs of VTAC, we have people that monitor heart rhythms on everybody on our floor. They give us a call and say, oh, your patient just had a run of 3. And that means they had 3 little VTAC episodes, and we got to go check on them. And sometimes it's perfectly normal, and it's no big deal, but we still take it pretty serious. And we have had patients that have gone into deadly rhythms, and then you have a code situation. And some of them have survived it and some have not, depending on their underlying other health issues. So what we can say about 99% of cardiac muscle cells is the action potential is longer than we see in a skeletal muscle cell. It has calcium influx at the top of depolarization, which causes a plateau and lengthens the repolarization period to allow time for the heart to fill with blood. But the potassium causing repolarization and setting things back down to normal is just the same as we saw in nerves and skeletal muscle cells. So now we'll talk about these autorhythmic cells. These are cells that can generate their own action potential. So where do we find these cells? Well, maybe we find them in the SA node, the AV node. You've heard of those from general A&P, right? The bundle of His, bundle branches, the Purkinje fibers. All of these cells on that electrical pathway can generate their own action potential. We call them autorhythmic because they set the rhythm of the heart all by themselves. Auto means self. It doesn't need any outside stimulation. So if we look at this type of action potential, we call it the pacemaker potential because it happens automatically. It does not need an outside stimulus. So what we have are slow sodium channels that open up all by themselves, that as long as the membrane potential is down between -55 and -60, they open up all by themselves. And then once it drifts towards threshold, it fires off a depolarization, but the depolarization here is not sodium again, it's calcium. So we have slow sodium channels, then we have voltage-gated calcium channels, and then again potassium. So potassium, it doesn't change. It still causes the repolarization. But the pacemaker potential, this automatic opening of channels, is due to slow voltage-gated sodium channels. And they just automatically open when potassium channels close down here at -60. That opens these, that triggers the opening of the slow voltage-gated sodium channels. And then again, number 2, this rapid upward shift of depolarization is due to voltage-gated calcium channels. So both action potentials that we see in cardiac muscle cells involve calcium, wouldn't you agree? And they're kind of the second player in the game, right? The first player is always a sodium channel. So when you go back to this one, 99% of heart muscle cells, what type of sodium channels are at number 1? Fast voltage-gated sodium channels. And you can see how rapid that depolarization, that goes straight up over a very short period of time. And then number 2 is voltage-gated calcium coming into the cell. So calcium's coming in. Number 3 is potassium. So going back to this one, what type of sodium here? Slow sodium. Number 2 again, voltage-gated calcium. And number 3, voltage-gated potassium. So the movement of ions is not changing. It's just where calcium comes in. And in both situations, it's the second player. Does that make sense? So what I would recommend is, I gave you a study guide, I believe, did I not, for this first unit where you draw a picture of the action potential, or we compare them? Is there a page for that? Yeah, so there's like that study guide packet. We'll talk about that once we're done with the notes. Whoops. So we call this the intrinsic cardiac conduction system, which means I can take this heart out of somebody, I can take your heart out of you and put it in somebody else, and it would beat all on its own. Would you agree? It does. It can beat all on its own because the SA node is the boss. The SA node fires at the fastest rate. And as we move down the conduction system, it gets a little slower every time. So the SA node fires at a rate of about 100 beats a minute. But because of parasympathetic stimulation also serving the heart and acting on the SA node, that brings it down to about 75 beats per minute. So the SA node, if I took the heart out and gave it to somebody else, their heart rate would be about 100 beats per minute. But the parasympathetic nervous system would slow it down to 75 if it was hooked up to the nervous system of the donor. So the AV node beats slightly slower than that. I'm trying to find where your textbook talks about the different rates of these. It used to talk about that. I know I have it in my general A&P notes. So the SA node beats at a rate of 75. If the SA node would shut down, and this happens, people that have heart attacks and damage to muscle cells around there, they can also have damage to their nodes that are supposed to be stimulating this autorhythmic contraction. So the AV node can take over, and that beats about 50 times per minute. Then let's say the atria, something's wrong with the pathway from the atria to the ventricles, and now the ventricles have to just beat all on their own. We see heart rates where just the lower part of the conduction system is functioning. We're looking at about 30 beats a minute. So if you look at a patient who has a blockage, a conduction block, we call it a bundle branch block. So there's a block in that pathway going down to the ventricles. We'll see very low heart rates because of that. And we're going to study EKG and look at different heart rates and study this conduction system in a little bit more detail. So I don't want to go into a lot of detail on that right now. But just be aware that low heart rates mean the atria, the SA and the AV node, are not communicating with the ventricles. And there's some type of blockage in the conduction pathway, not in blood flow, but in the conduction pathway. So slow heart rates indicate it's just a ventricular rhythm that's going on. All right. So I'd like to look at that handout I provided on black. Looking at number 1, waves of depolarization. How do they spread among muscle cells? Gap junctions. Very good. Gap junctions. What do they cause the ventricular muscle cells to do? Depolarize and contract. Yep, depolarize and contract. So the 3 channels essential for generating that action potential indicate which way the ions move. So what channels? Sodium channels. They go, the ions move into. Calcium channels, ions move into, and potassium channels move out of. So if the sodium or fast calcium channels are open, the inside of the cell would be relatively more positive. So the pacemaker potential is due to efflux, means out, is due to a blank efflux of what ions compared to a normal influx of what ions. Pacemaker potential. Say again? We say there's all right. So for number 5, the pacemaker potential is due to a decreased efflux or loss of potassium compared to a normal influx of sodium ions. Because remember, that's the concentration gradient. They normally, right, potassium normally wants to leave the cell, sodium normally wants to come in. So the threshold for the action potential in the SA node is what? If you look back at your negative 40 millivolts. Yep, if you look back at your diagram from your notes, it's negative 40. What channels open causing depolarization? Calcium. Yep, voltage-gated calcium channels open up at negative 40. The reversal of membrane potential causes what channels to open? So now we're coming back down. Potassium causing what happens? Repolarization, good. And number 8, everybody knows this one, I hope. Sodium-potassium pump, yep. Where is calcium stored in the contractile cells? The SR, sarcoplasmic reticulum. And gap junctions allow what cations to pass into the cardiac contractile cells, causing the opening of voltage-gated sodium channels? Calcium, positively charged ion. All right, state the voltage-gated channels responsible for the action potential in cardiac contractile cells. So when you talk about contractile cells, we're talking about 99% of cells in the heart muscle. So this is the other action potential we talked about that has the plateau, remember? It flattens out a little bit at the top. So depolarization is caused by fast, say again? Sodium channels, right? Fast voltage-gated sodium channels. And the plateau is caused by voltage-gated calcium channels. And the repolarization is always the same, voltage-gated potassium channels. Yes, yep. Technically, yes, technically. But what causes the plateau is specifically calcium. Yeah, because otherwise it would just dip right down. So this is just a review. What channels in the autorhythmic cell allow ions to leak in? Slow sodium, voltage-gated sodium channels, yep. And what channels in the autorhythmic cells bring about depolarization? Autorhythmic, calcium, voltage-gated calcium channels. So label each square showing what ion is moving in. So what type of cell are we looking at in this diagram? Pacemaker. So it's our 1% of cells. So we're talking about cells in the SA node, AV node, bundle of His, Purkinje fibers, all along that conduction pathway. So we call them autorhythmic or pacemaker cells, 1% of heart muscle cells. So down here, what's the ion? Sodium, and it's going what direction? In. And here, calcium going in. Here, potassium going out. And then this is just threshold. And what do we call this whole thing from here to here? Pacemaker potential. Yeah, because it's not caused by anything. It just drifts on its own. And then here, repolarization. Okay, so the next one is our other type of channel. So what is this one? Contractile muscle. We call it contractile muscle cell. So what's happening at 0 then? Fast sodium channels, right? Fast sodium channels. And at 1, voltage-gated calcium channels are opening. 2, well, yeah, 1 is potassium because we see the slight drop, but as more and more calcium channels open, it plateaus. So yeah, 1 would be potassium channels opening. And then 2, this whole segment here is voltage-gated calcium channels, and then 3, only potassium channels are open. And then 4, you're just at resting again. So here, the type of cell is just a skeletal muscle cell. This is outside of the heart, right? Anywhere else. And then this would be voltage-gated sodium, and this is voltage-gated potassium, and you're done. So of these 3 graphs, which of them require a stimulus from the nervous system or another cell? The skeletal and contractile, right, and the contractile. So again, I can create an action potential by using an AED on the surface of the skin, right, and providing an electrical jolt to those cells. Or the conduction cells, the autorhythmic pacemaker cells, generate that action potential through those gap junctions. So if we compare these across the board, what is the resting membrane potential of skeletal muscle cells? In your textbook, it differs from textbook to textbook, but it's in chapter 9 of your textbook. Do you remember what it was? It's -70 for nervous system cells because we need more rapid response. But in skeletal muscle cells, it's actually -90. And in cardiac muscle cells, what was it? -55 to 60, right in there. I'm trying to find your other, here it is. For the contractile cells, though, it's lower than that. It's like, that's the threshold, but the next line isn't shown. It's about -90, though, based on what I can see in your textbook on page 683. So what brings about the initial depolarization in skeletal muscle? What stimulates skeletal muscle? Action potential in a motor neuron, right? Action potential in a motor neuron. What stimulates cardiac muscle cells? Or what brings about depolarization? Stimulus from a nearby pacemaker cell. So action potential has to be generated by a nearby pacemaker cell. And then lastly, pacemaker cells. It can do it on its own. There is no stimulus. Type of ion channels that bring the cell to threshold. So voltage-gated sodium channels, voltage-gated sodium channels, voltage-gated sodium channels for all three. Would you agree with that? We have fast in the contractile cells, and we have slow in the pacemaker cells for the cardiac, but all three, it's sodium channels bringing them to threshold. What opens at threshold? Actually, if we think about the type of ion channels that bring it to threshold in skeletal muscle, that's still voltage gated. Well, no, they're not voltage gated. What is it? It's at the neuromuscular junction. Ligand gated, yeah. Remember acetylcholine has to bind to those channels? So it's actually ligand gated sodium channels at the neuromuscular junction that brings these to threshold. And then cardiac muscle, contractile cells. What channels bring that to threshold? What do you think? Those contractile cells, they can't generate their own action potential, so how do they? What stimulates them? How do we get that action potential there? On page 683 of your textbook. Well, it's sodium, but what causes it? Yeah, pacemaker cells. Pacemaker cells stimulate that, so it happens through those gap junctions. You get enough sodium flowing in, right, to bring it to threshold. Yes. And then the pacemaker cells, they don't need their own action potential. And the SA node, because it fires more rapidly than any of their cells, it's like the pacemaker of the heart. So its action potential spreads down the conduction system where the other ones don't have to rely on their own intrinsic rate. They just fire at a faster rate. All right. Ion channels that open at the peak of depolarization in skeletal muscle, potassium in contractile cells, calcium, and then in the pacemaker cells, what is it for pacemaker cells at the top? Potassium again. Yep. Ion channels that cause repolarization in all three is potassium. Is skeletal muscle influenced by parasympathetic or sympathetic stimulation? Now we got to zoom out and not get stuck in the trees forgetting the forest. Zoom out. What is the autonomic nervous system? What are the three things I told you to remember with the autonomic nervous system? Three things they stimulate. Cardiac muscle, smooth muscle, and glands. So is skeletal muscle any of those three? No. So skeletal muscle has nothing to do with the autonomic nervous system. Remember the somatic nervous system we talked about? Yeah, so no, the answer is. Contractile cells, are they influenced by the parasympathetic or sympathetic nervous system? Yes. Because we know that epinephrine goes to the blood, right? Which binds to receptors on the heart. What type of receptors on the heart bind epinephrine? Beta. How many hearts do we have? 1. Beta 1. Okay, so yes. Are the pacemaker cells stimulated by that? Well, what did I say the intrinsic rate of the heart would be without parasympathetic stimulation? It would be about 100 beats a minute, right? Vagus nerve slows it down to 75, so the answer is yes. Can they contract without input from the nervous system, the skeletal muscles? No way. Contractile cells? Yes, with the help of the pacemaker cells. Can cardiac muscle cells contract without the nervous system? Yes, yeah, that's what makes them special. So in which cells is the action potential the longest? Contractile cells, yep, contractile cells. And why is that important? Yep, gives the heart, when it's relaxing, time to fill. That plateau is just a resting period. It's repolarizing. The heart's no longer contracting. And in which cells is the action potential autorhythmic? Pacemaker cells. Why is that important? It doesn't require the nervous system's input, so the heart can keep its own beat, and it can respond to the needs of the heart itself. You don't have to write all that down, but it does not rely on the nervous system. So if there's something wrong with the nervous system, the heart is still going to beat on its own, because it's very important that it beats to keep the body alive, right? So we don't want to rely on nervous input. We want to be able to have that heart beat all on its own. So in which cell is the absolute refractory period the longest? So that means when we're actually in the middle of an action potential, which one would you guess would have the longest refractory period then, that you can't get it to contract again? The contractile cells, again, because of that plateau, that's important. Again, allowing time for the blood to fill and completely eject the blood that's in the heart. Because too high heart rates, we don't have enough blood leaving the heart or returning to the heart, and as a result, we don't get that pressure and volume leaving the heart to serve the tissues, and a person passes out. So the next picture on your diagram talks about the cardiac cycle. So we'll pick up, that's the next topic in our lecture, and we'll talk about that in cardiovascular number